We take great pleasure in inviting Dr. Meenakshi ma'am, Dr. Rizwana, Dr. Vishwanath as panelists and our moderator Purnima. Over to you, Purnima.
Thank you, ma'am. Good evening, everyone. Welcome you all to OATN I Teach webinar series. So we have some eminent speakers with us on the panel to discuss about managing the myopia epidemic post-COVID-19. So first of all, I would like to welcome Dr. Meenakshi Swaminathan, who is an American board-certified pediatric ophthalmologist. She did her MS from Postgraduate Institute of Medical Education and Research, Chandigarh, and she's also trained with Dr. Bill Scott and late Dr. Ronald Keach at the University of Iowa. She has been in academic practice at Shankar Nethralaya for the past 18 years, and she has also been the Director of Academics for past 15 years. She is passionate about education and has worked with Orbis and ICO on many occasions. Her special interests include complex strabismus, nystagmus, myopia with special needs. Next on the panel, we have Dr. Vishwanathan, who has completed his PhD from Anglia Ruskin University, Cambridge, UK, on near-work-induced transient myopia among myopes and non-myopes in Indian subjects. He has also completed his FDDO and is an alumni of Elite School of Optometry. He heads the optometry department at Shankar Nethralaya since 2008 and has over 2 decades of clinical experience in various areas of eye care. He currently is the assistant professor at Elite School of Optometry and is involved in teaching undergraduate and postgraduate optometry students. He has presented and participated in various national and international conferences. His current area of interest is myopia control, and he is the chief optometrist at Myopia Clinic in Shankar Nethralaya. Next on board, we have Dr. Jamil Rizwana. She heads the binocular vision or vision therapy clinic at Shankar Nethralaya. She is currently the assistant professor at the prestigious Elite School of Optometry. She is the first clinical diplomat from India in the section of binocular vision, perception and pediatric optometry of the American Academy of Optometry, AAO, and is the inaugural president for the AAO India chapter. She is a renowned optometrist and receives referrals from across the country for her clinical expertise. We welcome all 3 of you on board. Ma'am, over to Dr. Rizwana.
Okay, thank you, Pungode ma'am and Purnima for the introduction. So all 3 of us are very, very happy to be here today to address about managing the myopia epidemic post-COVID-19. So this is going to be an interactive panel discussion where I will be kind of moderating the session and then putting forth questions to the 2 experts in the panel today, Dr. Meenakshi ma'am and Dr. Vishwanath. So now that we all know about this word pandemic, there's always been debate about should we also start calling myopia as pandemic with all the increasing global prevalence that we got to see over the last decade. So before we begin, we just want to, all 3 of us want to declare that we don't have any disclosures. And so the overview of the presentation today is going to be, first, where are we now, okay, in terms of being able to use evidence-based data and approaches to understand the global burden of myopia, because now everybody talks about evidence-based and evidence-based. So we need to have strong evidence to really discuss about, is it important, like is myopia important, and how myopia is going to look like post-COVID-19. So that's the first aspect of today's discussion. The second aspect is about all those unanswered questions, okay, like this, for example, when will this pandemic end? Or does near work and myopia are associated strongly? Can we prevent myopia from happening at all, and questions like that. So what are those unanswered questions, and how do we use the available evidence to be able to answer that? And then the next thing is about some of the potential stories that we might end up hearing now that all of us have started to get back to our clinics and have started to see patients. What are those stories that we might be hearing now in the post-COVID-19 period about myopia? And what's already happening? So what would the clinical picture look like? So we will be using case-based examples to kind of China and, but the rest of it is all close to these numbers. And then, so these are all studies in and around the same duration, like, from 2013 to 2020. And all these studies are like just showing that even within a very short period, myopia prevalence has had a great jump. This is pre-COVID world that we are talking about, and all these prevalences are based on cycloplegic autorefraction. Okay, cycloplegic autorefraction values in children. And this is a paper that we will be using in most of our discussions today, which is a very nice paper that just came out about the review on the epidemiology of myopia. So the projections that I showed just before is also from this paper, where they've given age-wise breakdown in myopia prevalence. And then look at our country. So what this tells you is that the peak age of prevalence, basically. So for us, it's actually at 12 years when myopia really peaks up, and then that's where the major prevalence or incidence is seen. And then you see the rest of the countries, and of course, the more bluish, the prevalence is more. Okay, so now that I'm going to stop here and then get into the panel discussion at this point. And the first question that I want to ask is to Dr. Vishwa about our own experience. Now that we've shared data from across the globe, what is our experience from the STEM study?
Thank you. First of all, before I begin, I would like to thank OATN, all the members, and thanks for the introduction, Purnima. So, STEM study is Shankar Netralaya, Tamil Nadu, SL or myopia study. It is actually a we have screened about 14,831 children across 10 schools. We selected schools from Tiruvallur district, and what we found was the prevalence of myopia is almost similar. I think Rizwana shared the prevalence of North India myopia study, and this prevalence of myopia here is about 12%, which is very similar to North India myopia study prevalence. And the prevalence of high myopia in these kids are less than 1%. To be precise, it is about 0.64%. One of the things that we have consciously used in this study was open field autorefractometer, because we wanted to assess, as you all know, that cycloplegic eye drops, we can't use it outside for the reasons that you know. So we used open field autorefractometer, and for all the kids we assessed BV anomalies, and we also used ocular biometry parameters. So these three are very unique from the studies which have been published earlier. We also collected the lifestyle questionnaire just to understand their, to know about their outdoor activities, how many hours of time is being spent on outdoor, and how many hours of screen time. All these data we have collected. This 14,831 children is the data of the first year, and we will be following them for another 2 years. Thanks, Chris. Over to you.
Okay, thank you, Dr. Vishwa. And now it's over to Dr. MS, ma'am. So this is a question that I have always wanted to ask you, ma'am. Okay, now that you're practicing over the last 2 decades, what is your experience when it comes to myopia? Like, how do you really see it like a decade back and now?
Let me unmute myself.
Yes.
You can hear me, right?
Yes, ma'am.
Okay. So, When I started my career, which was 2001, and we were all taught that there is something called congenitally high myopia, which would usually not progress much. And then there was school-age myopia, which typically started about 8 to 12. And that was that. And that would progress, and we would all blame it on hormones. And we would say, your body is growing, your eyeball is growing, and hence your myopia is increasing. And that was about it. Remember those days, there was at the most television. There really were not that many gadgets prevalent. So we would be asked by patients repeatedly about distance from which they should be viewing the television, etc. I don't think even academic pressures were that intense with coaching classes and JEE and what you will those days. So I think kids perhaps still had alternatives to go out and play. Everything was not chock-a-block apartment complexes. So children did have some spare time, free time, but that was all about myopia. We really never took it that seriously. And then, of course, about 10 years ago, perhaps, I started noticing the increase in prevalence. That was about the time when we were becoming more and more digital. Kids were getting on iPads, the affluent ones. Then slowly, homework was all being sent on WhatsApp, which is, I think, the transformation in the last few years. And the intense academic pressure, there is no time for children to go out and play. They go typically from school to a tuition or a coaching class, go home, do more homework, and then the cycle repeats. So when I was asked to give a oration lecture, this was about 7 or 8 years ago at LV Prasad, that's when I chose this topic, which said, progressive myopia. Are we on the verge of an epidemic? So for me, because I felt that the time had come to really look at what we are on the verge of, look at what we know already from Southeast Asian countries. And there was hardly any data from India at that time. What do we know about India? And what should we be anticipating in the next decade or two? So I would definitely answer your question by saying, while just being one of the other refractive errors 20 years ago, now it's probably 50-60% of my patients on a daily basis, which are progressive myopes.
And that gives us a really a clear picture about how the onset of digital era and the increased academic pressure and stuff like that has changed not just the kids' world but also the myopia. So now that you also mentioned a couple of risk factors when you were speaking about your experience, so you can just summarize about what you think are the modifiable risk factors and what are the risk factors in general that a clinician needs to be aware of?
I think number one out there, even though there are a few studies that don't support it, I still both commonsensically and support from literature tells us that near work, the number of hours of near work, which is calculated as diopter hours, and how close you view your near work, and how continuously you end up doing hours and hours of near work without breaks. So near work, number one. And in gadgets, when you use gadgets, for most families, their go-to gadget, especially in India, is either a phone, a smartphone, or a tab. Not everybody can afford a smart TV. In fact, when there are parents who I feel are from families who can afford, that's what I tell them to please invest in a smart TV for your child's sake. Project everything onto the screen. mirror everything onto the screen, and that will put some dampening on the progression. So number one is near work. And you said modifiable, so I'm not talking about genetics, but yes, perhaps, maybe I'm stretching myself in saying, if there are both mom and dad are myopes, both groom and bride are myopes, maybe rethink that marriage, so, or maybe a controversial thing. The second most important modifiable factor is outdoor light, which has been the subject of study extensively. And there are so many ways in which people monitor the outdoor light exposure. We have been talking about it with cloud clips that clip onto your glasses that say how many hours the child is exposed to the outdoor light, whether playtime by itself, by just the outdoor light is protective, or is it because it reduces the near work hours? It's not clear, but there seems to be a lot of literature support about increasing outdoor time. Outdoor light.
You've seen that the kids' academic pressure has increased. The study also quotes that especially if a child has just 4 hours per day of near work, okay, which is common for every child, then he's likely to have about 120% of additional odds of myopia. So just 4 hours of near work in tutorial classes after school, in additional to school work, is going to put the child at 120% of additional odds of myopia. So that's data from this paper. And so just to bring the other risk factors from, again, the evidence, as ma'am rightly said, low outdoors and time spent on near work being the most important modifiable risk factors. As you see, genetic factors like parental history of myopia, being female gender, and the other things which are like the higher socioeconomic status, because you have more access to these gadgets. Use of LED lamps for homework, especially studies from China. That's just one study, so we need to really look at the methodology of the study. LED lamps compared to incandescent or fluorescent puts the child at more prevalence of myopia. Urban population, environment, and some studies say rural environment. Maybe because in Saudi Arabia the situation is very different, and private schooling, low sleep hours. So we're going to talk about all that as we move forward. So as ma'am was just mentioning rightly about the association between digital screen timings and myopia, if you see, different studies will give you different results. This is a recent review that kind of tells us that still there is not a very well established association, but maybe it is because that it is all from data. Everything is questionnaire based. You ask the child how many hours do you indulge in gadget use and near work, and then you ask the parents, and then so such modes of questionnaire-based data collection is prone to a lot of bias, as we all know, depending upon the recall, and then whether you want to tell people about the number of hours of near work that you're really doing and things like that. So, so there is this recent study which is a kind of a very good methodology as such, used what ma'am mentioned, what we call as the cloud clip. So this has very important implications for the practitioner that we will talk about a little bit later. This is nothing but an infrared sensor-based device that's going to go along onto the child spectacle frame, which is going to give data to the clinician about the number of hours of near work, the exposure to outdoor illumination levels, and then the angle at which the child's head position is. And it's also going to give warning when the child goes very close to the desk or book when the child reads. Okay, and it's going to kind of give a warning signal, it's going to blink. And so this is one another device which is kind of occupying its place more in terms of epidemiological studies, but I don't see that the day is too far for it in the clinical situation. So for example, from this study, what they say is that, as ma'am said, walking distance which is less than 20 centimeters especially, puts the child at risk of increased axial length, and thereby increasing the risk of myopia progression. And whenever a child is exposed to ambient illumination, which is anything more than 3000 lux, is associated with non-myopic status. So what do we mean by that? Is children who are emmetropic or not myopic yet does have longer hours of exposure to anything above 3000 lux compared to children who are myopic. And so myopic children, of course, show reduced light exposure, reduced number of hours spent outdoor, and show shorter working distances. So this is from this particular study. And so we're going to be looking at two studies that just came out. Number one is, may home confinement during the COVID-19 outbreak worsen the global burden of myopia by Pellegrini et al. And the second study is, what do we do to mitigate the effects of home confinement on children in general, not just on myopia, but in general. So these are the two studies that we're going to be discussing over the next couple of slides. So the first thing is the problem statement. So as we all know, now that schools are closed, so according to the UNESCO, more than 160 countries have closed the schools in the attempt at containing COVID-19 spread. And this is about 87% of the world's student population. Now that, all of us as adults, we know we can sense the anxiety that we have, but when it comes to children, it's all about, that they're not able to stay in touch with their friends, and that has got an effect on their physical and mental health. Because none of us know that how long is this, pandemic going to be with us. And lack of, touch with their classmates, friends, and teachers. And the study also says that there's a lack of personal space at home, and the anxiety among parents, especially in terms of financial loss and things like that, have long-standing effects on both kids and adolescents on physical and mental health, resulting in irregular sleep patterns, affecting their cardiorespiratory fitness. So it's not just about the eyes, it's actually about the holistic well-being of the child. And then this whole terminology is being proposed, quarantine myopia. So we're going to hear more and more of this term, I think, in the post-COVID-19 period. And why do we have to worry? Okay, now that everybody is having the same anxiety, when it comes to low and middle income countries, all know that, the myopia epidemic is catching up. Definitely a prolonged home confinement is going to increase the prevalence of myopia and also the global incidence of myopia. And studies clearly has stated that every diopter increase in myopia is associated with a 67th increase in the prevalence of myopic maculopathy, and this is going to not just impact the vision, but it's also going to be sight threatening. So this is the problem statement that is right in front of us with this whole COVID-19 situation in place. So now with this, I'm going to actually ask questions to the panel, to Dr. Vishwa first, about how do we really handle myopes in our clinic currently? So what do we really do? How do we do the myopia workup? That's the first question, Chief Sir.
Yeah. Ma'am did mention about, so I'd like to just tell here that when do we call a myopia as progressive myopia is when we see a change in perical equivalent of more than half a diopter, say from 0.75 diopters from the previous year visit. So then we term them as progressive myopes, and we do cycloplegic refraction, and when we find that when there is an increase in myopia more than half a diopter from the previous visit, what we also do is we do BV assessment. Mainly we would want to understand the amplitude of accommodation, the pupil diameter using open field autorefractor, and then they are being referred to the myopia control clinic. Mainly we would assess the history because we want to understand one of the risk factors, as ma'am said, that parental history is very, very important for us to understand. So if one parent is myopic or both the parents are myopic, and if they are progressing, then, and if they are as are 7 years, they are termed as early onset myopes and the progressive myopes, which means that they would progress much faster than the other myopes. So we want to really take care of them. We don't want to progress at a much faster. We are going to discuss about some of the complications associated with the high myopia and the progressive myopes as well. So one of the things that we assess is the progressive myopia and with the cyclorefraction. And the other important thing, some years ago, we were not measuring ocular biometry parameters But for the last 3 years, we are measuring ocular biometry parameters using non-contact biometers. The reason is very simple, because even if they are say -3 or -4 diopter of myopia, but if the axial length is greater than 26 mm, I would want to definitely dilate and look at the fundus image. Also, would advise OCT to look at the macula. So these are some of the management decisions that we need to really consider in case when the axial length is greater than 26 mm. So it would definitely help us to decide the management in a better way. So let me reiterate. One is the BV assessment. The second thing is ocular biometry. And then we call them on a frequent visit. Suppose if first time when they visit us, we just document the baseline measurement and we don't consider any of the control strategies. And we call them either 3 months.
Yeah, so regret the technical difficulties that we had to face. So we just finished with the question to the panel, and now we're moving on to our case discussion. So this is going to be more interesting now. So the first case for the day is about a 12-year-old child who's already wearing glasses over the last 5 years, and he was referred through school screening initially. And parents could recall that the refractive error was about half a diopters to begin with, and the last the spectacle prescription is about a year old. And as you can see, he's wearing about -4 diopters with 1.25 diopter cylinder across 180 in the right eye, and the -4 diopters here with 1 diopter cylinder across 180 in the left, and the visual acuity is 6/12 and 6/9 in the right and left eyes respectively. So if you just keep this in mind, this -4 and -4, and then now when he's come for a regular follow-up, we are getting a refraction of -4.5 diopters in the right eye and -4.25 diopters in the left eye. So a half a diopter increase in the right and a 0.25 diopter increase in the left over this last 1 year. Not much change in the cylindrical prescription. So assuming that this child has now come to us post-COVID and the geogram is all balanced, my question to MS ma'am now is that if we get to see this in our private practice, can we go ahead and prescribe in this scenario in the absence of cyclorefraction, ma'am?
I think given the child's age, so subjective refraction, subjective acceptance is likely to be reliable, number one. And the amount of progression seems to be keeping in line with his vision. He's 6'12", 6'9", and we have seen a progression of 0.5 and 0.25. So that's point number 2. And 3, duo is balanced, which is something we rely quite a bit on. And again, potentially an older child, so reliable responses. I think keeping all this in mind, I think it's reasonable to prescribe at this current scenario when you do a cycloplegic refraction and it's going to really increase the amount of clinic time for the child, that much more risk of exposure, etc. I think it's reasonable to prescribe even without cycloplegic refraction in this particular case. Of course, like I already said, keep that component of pseudomyopia in mind. And while you're doing a dry retinoscopy, ensure that you're not missing that.
Okay, ma'am. So looking at the stability and the age and the previous history, you feel is a very predictable change, and you kind of advise that yes, in the absence of cyclorefraction, we can still prescribe. And so as we continue with this case,
Donna, may I ask you a question?
Yes, sir.
In the previous question, as ma'am said, I think we can go ahead and prescribe. But would any additional procedures would add value in that case?
Yeah. So I was coming to that. So as ma'am was, keep emphasizing about this component of pseudomyopia. So as practitioners, I think we can actually utilize 2 potential tools that we've got with us. The number one is our dynamic retinoscopy or the monocular estimate method retinoscopy, whereas all of us know that the expected lag of accommodation is anywhere within plus 0.25 to plus 0.75 diopters. So if you are, after doing the subjective acceptance and you perform the dynamic retinoscopy and you are able to see the values just between this, then we can be even more confident that we are not dealing with the pseudomyopic component. The second thing is to check the folia status, which, as ma'am is again emphasizing, any ESO that shows up when you do the cover test will again be indicative of a pseudomyopic component, and then we'll have to you'll have to look at referring this child for cycloplegic refraction. So these are the two additional procedures I would recommend for such particular cases. When you're all confident and set to prescribe, but just want to ensure that we're on the track, then these are the two things that I would ensure. And yeah. So thank you for asking that question, sir. And now moving ahead with our second case, which is an 8-year-old school-going kid. And the mother was just starting to notice an inward deviation of the eye. She was telling us that it was very intermittent, but then I'm seeing that the child kinds of squints and brings the eyes too close to the nose. And the child has never used glasses, and the mother has just brought the child for a regular examination before 3 months, where the child was emmetropic. And when we do the assessment, we find that we are not able to get an accurate estimate of the refractive error, and we start to see this little bit intermittent esotropia, measuring about 12 prism diopters of esophoria, especially at near. The accommodative amplitudes are fine, and then when the child especially goes to the esotropic phase, he says that he's seeing double. Okay, and visual acuity, especially he is very some certain things that something that we commonly see in such kids, where they just say if I don't do anything and I just stare at the chart, it's only 6/18, but then if I just blink, then it just improves and it becomes it goes back to the worst visual acuity. So I want to ask ma'am, as so before I ask, I'll just give other key parameters that we measured in this case, which is the cycloplegic refraction that we have to get done. And after cycloplegic refraction was done, post cycloplegia visual acuity was measured, and it was found to be 6/6. Okay, just after the cycloplegic installation itself, after the 45 minutes, and intermittent esotropia disappeared in 3 days. So this is just for the practitioners over here, where over the last couple of years, we might have seen a lot of case reports coming from different parts of the country and the world, where this whole excessive smartphone usage leading to acute comitant esotropia and diplopia, especially in this particular case series, where it's all 8-year-old, 10-year-old, and 12-year-old male kids who had diplopia after using the mobile phones, ranging between 6 hours. An average of 6 hours per day, very similar to the quarantine timings. And another paper again from outside the country, where this is 12 patients. Mean age was 13 years, and again 7 of them were female, and all of them had esotropia after smartphone use. So now that the question is, this is a recommendation that the American Academy of Pediatrics had given us, which was the earlier guidelines was 18 months or younger, no screens at all, and from 18 months, limit the screen time. And so now that the guidelines itself is revised, which is earlier even 18 months to 2 years did not have a screen time component, but then it was later added before the COVID itself. Now, when we see such kids, ma'am, what is your advice to the child or parent, or first, how do you really look at managing this situation?
I think it's very clear what's going on. First of all, 8-year-old coming with this kind of scenario with blurred vision and autorefractor, and your initial checkup shows myopia in a previously emmetropic child who spends locked up in lockdown with his gadgets and smartphones and such. you really know what's going on. You know that you're dealing with a form of accommodative spasm, which could be anything from child escaping to it because of parental pressures at home, peer pressures of having to play games online, etc., of having to keep the teachers happy by doing excessive research. Whenever I ask a child, what are you doing at age 8 and 9 on the internet? They always tell you, they've given me topics and I need to research. So they're all on the internet, even using a smartphone, looking up things on Google, using Google search and having to write little projects or whatever they have to do. So it is a very complex and in its own way stressful scenario where the child is now, especially with the quarantine. So I think you really need to speak to the child separately. You need to speak to the parents separately. You have to impress on the parents not to breathe down the child's neck on keeping interactions useful, keeping everything they do useful. I'm sorry, the sun is in my face. I'm just getting out of it. So it's very imperative that we speak to the parents to make them understand that the child needs to be given downtime, child needs to be given relaxation time, because even if you propose saying, look, you need to relax your eyes every 20 or 30 minutes, this can only be enforced by the parent. A child of 8 or 9 is not mature enough to remember to relax and to look at far objects and to take breaks, etc. So it really needs to be enforced by the parents. So I think a conversation is in order for both the parents and to the child. And do you have that? As I was, do you like me to share that resource material that I was?
Yes, ma'am. Yes. So I think I'll just show. So this is a resource material that ma'am shared today with all of us. So you can just talk about it, ma'am, while I open it. Yeah.
Are you going to be sharing it? Or do you have?
I'm just opening it, and Purnima, just let me know if the screen is seen.
Pardon?
If ma'am, can you see my screen with that material is opened, or do you still see the PowerPoint?
I still see the PowerPoint.
Okay. So I'm going to share again. This is always a.
So
you can just keep going. I've opened it. Yes.
Okay. So we have a group of pediatric ophthalmologists over the country, which is a large group on 2 WhatsApp groups, or over 350, 400 of us. And this is Dr. Bashini. She works at Shroff Charity Eye Hospital. She was both a DO and a DNB PG from Shankar Nethralaya and my fellow. So she has a young kid, about 8, and I think she was constantly questioned and harassed by so many concerned parents and colleagues that she decided to actually come up with a beautiful document talking about the screen time during lockdown. So I will just quickly run through this. It basically says, what will it do to the child's eyes, because suddenly the screen time has gone from 1 hour to 6 to 7 hours a day during the lockdown. And why is excess screen time harmful? How are the eyes affected? What really is the new normal? Do we have any golden rules to follow that we can share with our patients as far as screen time is concerned? And so she talked about how it is habit forming, reduces attention span. It also interferes with other things like delaying language development. So these kids tend to become introvert, and they become, their socializing behavior is affected. Their sleep patterns are affected. I always, when the parent says, child is sleeping poorly, his dark circles on the eyes, I always ask them, is he in bed with the room lights off with the phone? And you will be surprised how many of them will say yes. They will say he has the phone under the covers. It also impairs cognitive development. And if you look at short term, what all can happen, the eyes will look red, and sometimes they become with history like child is just constantly blinking the eyes, and kanna orediya symmetra, and kanna potu thechikra is what they will tell you, many of the parents. And as we just saw, sometimes it can even precipitate acute onset of esotropia and double vision. And once this is the short term. I mean, you look at the little bit medium term, they can also lead to myopia. This, of course, talks to parents, so it gives you in more layperson terms. And those who previously did not even need glasses may become myopic, and those who are myopic may continue to progress. And this can go on and on and on. We used to think myopia progression stops at about 16 and 17, and then we used to tell parents that, yes, the child can get a LASIK done after 18, but not anymore. We find myopia continues to progress long after 18. And as you know, this is going to lead to really catastrophic complications in the retina, can cause myopic macular degeneration. We know higher myopia has more glaucoma, etc. But we should also reassure the parents that this digital eye strain is temporary and reversible, and there are ways in which we can minimize problems for the child. So how can we adapt to the increase in screen time for children, which until school really opens, there's a lot of debate going on. Should we send children back to school at all? Or are we going to only look at online screen time education for the next many months or years? Is this the new normal, is the question. And so larger screens are better. As I talked to you already, I said, ask them if they can invest in a smart TV and watch whatever they need to, learn whatever they need to on a larger screen. Because smaller and brighter screens usually cause more strain. So if that's not possible, a desktop is a good alternative as well. And important is, as we already said, no continuous screen time. It is very important to give breaks. Not only blink while staring at the screen. Every 20 to 30 minutes, the child needs a break. And so I usually tell the kids, get up, run around your apartment, in your house, 3 to 4 times. Then drink a glass of water or juice, come sit and resume. Don't be casual. As I told you, many kids just get carried away in whatever they're doing. So you have to enforce the breaks. So it's important to even keep an alarm. Keep every 30-minute alarm in the phone. Keep it next to the child. Every time the alarm goes off, the child has to take a break. And don't try to fill the day with screen-based extracurricular activities once the school days resume. And so let's talk about the golden rules. Number 1, no screen time for children younger than 2 years. If you look at American Academy of Pediatrics, if you look at all guidelines, they'll tell you kids under 2 should not be exposed to a screen. But you would still see that parents saying, the paata potadan saapidra, and they will be showing that mobile in their child's proximity with some rhyme on it, and Dora jumping up and down or something like that. And that is when the child will open the mouth and eat. These are all very bad habits that need to be stopped right away. You have to go back to, Pati Tata Kada, like we used to, like our Pati and Tata used to tell us those days to make food go down. Next. No mobile phones, no supervised internet time, and no social media for young kids. So if you want to do it with them, you need to be holding the phone or the tab or the iPad at a comfortable distance. Have the child next to you on your lap, and then you watch content together. So also make the screen time productive. Maybe watch a documentary, start an art project together, make a YouTube video together, go tour a museum or a zoo together. Don't let the child on his or her own with the gadget. And monitor the entertainment, screen time, gaming, YouTube, and TV as strictly as before. It doesn't mean just because you have more time at home, you just go berserk. And it's important that you also don't stress about using screens for schoolwork, creative learning, and especially video chats with grandparents and family. A brief hello is okay, but it's okay, because in fact, if you look at the AAP guidelines, they say the only time they want you to use a gadget under 2 years of age is to do a FaceTime with a grandparent who maybe is longing for you. That is okay. That is acceptable. Those things are important for the child's growth. The kids need these social connections now more than ever because we live so far away. Grandparents, particularly now, cannot even come out of their house. They are in lockdown. So you may want to have a few minutes of FaceTime with them every day. And that is okay. Don't fret about it. And at night, no gadgets in the bedroom. And that is the only way you can ensure good sleep. Switch off all devices at least 1 hour before bedtime. Be honest. How many of you, including me, is still on WhatsApp and is still scrolling YouTube or lying in bed? This is something what the children are going to watch and learn. So you yourself should have the discipline of putting away the gadget, turning off all screens 1 hour before bedtime. On-screen activities are so important. Find those which your kids enjoy, challenge them to solve puzzles, online contests, read a book together, and you can substitute listening to the radio as podcast or even an audio book instead of a screen. We have just launched a podcast with in Shankaravidralaya. This is actually aimed at optometrists, ophthalmologists, all allied eye health professionals. We just launched it 2 days ago. It's just 10 to 12 minutes once a week. Something like that is meant for children is a great idea. Better than constantly staring at the screen. So exercise together. What was talked about. You happen to have space, do yoga together. And if you have an open area, let the child go there and play. Also ensures adequate sunlight exposure and also vitamin D. There's a strong association between a parent's screen time and their kids reducing parent-child face-to-face interactions and family time. So be a role model. As I told you, the child is looking at you, looking up to you. So be a role model and put that phone away. So we all know the 20-20-20 rule. Every 20 minutes, take a break from the screen for 20 seconds and look at something 20 feet away. So I tell my the parents as well and the child as well, look at a tenamaram, look at a syntax tag. You know, they don't know what is a 20 feet away. So tell them, Janal Variya Park, you can see that there. So look at that. That's 20 feet away. And then you can go back to whatever you're doing. So that was a great resource. I thought it would be nice for me to share it all with all of you.
Thank you, ma'am. I think this document is a very, very useful document for all the practitioners because it summarizes whatever that we've discussed in just layman terms. It also, emphasizes the important aspects and thanks for reinforcing those guidelines for all of us. And so moving ahead with the presentation. So this is one paper where we use this for your pre-survey. So for those of you who got your pre-survey questions, this is what we asked you from this particular paper. But in this paper, it's all about improving the awareness and knowledge of parents. And if so parents have better knowledge, then they can take care of their children's vision much better. So this is like 10 questions on a 5-point scale. So this just you must have answered this, and you will. We will share this resource with you. So for some questions, it's all about you want to strongly agree, but for some questions you don't want to agree. For example, long-acting midriatic agent is harmful to eyes, which is what parents think, but the myopia control world says it's not. So this is going to be strongly disagree. But if you are looking at question number F, which is corrective lens power should be less than your real power, since the full correction lenses may accelerate myopia progression, which is, many practitioners used to do that before, where we are undercorrecting myopia, but for this, it has to be strongly disagree. So this is a survey that now we run, as a pre-survey questionnaire for all of you. So you can even use this to understand parental knowledge and awareness and see how we can work on that. So ma'am rightly summarized about limiting screen time and counseling the child and the parent about the consequences of gadget addiction, visual hygiene measures that she summarized, and the important role of involving parents, because some of the recent studies shows that any child whose screen time is less than 2 hours and also exercises and gets between 9 and 11 hours of sleep are less impulsive. So it's not just about myopia, but it's about the holistic well-being of the child. So from this particular case, some of the potential red flags that we discussed, to summarize, if there is post-COVID, like, if you're going to get a child or an adolescent, what are those red flags that we need to keep in our mind and make sure that, we refer these kids? So the first thing is refraction related, which of course what we saw so far is any abrupt change over the last 3 months, because as all of us know, this is the time when all of us are engaged in more near activity. So it could be most likely quarantine myopia related to spasm or pseudomyopia, but not a true progression. And any progression greater than or equal to half a diopters within the last 6 months definitely needs a cycloplegic confirmation. Any acute onset of blurred vision, it just says like child says, like from yesterday I'm starting to see everything blurred. And then a variable refraction, as you would notice in both retinoscopy and autorefraction. I would want to emphasize this point here, especially for practitioners that rely on autorefraction for refractive error documentation. So the last case, the 8-year-old child, so we also did an autorefraction before cycloplegia that showed minus 5.5 diopters. And then, all of us were scared, in fact, and then after cycloplegia, it showed plus 0.7 diopters. So that is how strong these spasms of accommodation can be in younger children. And this is what we are expecting, especially in the post-COVID situation when we see these red flags. So refraction related are 4 issues, and binocular vision related, as we were emphasizing again and again, it's about using the dynamic retinoscopy to the best of our advantage just to see if there's any large lag, anything more than 0.7 diopters, or any lead of accommodation is abnormal, near ESO deviation, and pupillary size differences, like if you see this meiosis coming in as you do this retinoscopy, that's the best way to pick up this meiosis, and which is actually termed as spasm of near reflex. So it's very important to be aware of these red flags and make a decision about cyclorefraction, because if you're going to prescribe these glasses, it's going to do more harm than good. And as ma'am said, orthoptic exercises and other visual hygiene measures can play an important role in these kids. So we have 4 more cases that we are going to give you as a survey after this panel gets over, and then so you will actually get more insights about, okay, how do I manage this, and then we'll also share the answers with you after you finish the survey, because I think through cases we learn more than actual discussion. Now we're moving on to the last bit of this discussion, which is, okay, now that we see a true progression, or we are like, especially ma'am, I want to ask this question, that a parent is going to ask you that my kid is not myopic, but then he's like engaged in a lot of gadgets and near activities and stuff like that. So what are the myopia control strategies that you would advise them? Of course, we're going to reinforce so many things we've discussed so far, but then if a child is not myopic yet, what is preventative measure?
I think, if I recall correctly, it was part of the Guangzhou eye disease study, where they separated the kids who were not yet myopic into 2 groups and put one through 40 minutes of outdoor light exposure, and the other was the control, which went on as usual in the class. And this showed that there was a reduction in the incidence of myopia, onset of myopia amongst the children who were exposed to light. In fact, it is said that this study paved way for glass classrooms where natural light would come in. So I think there is your answer. So you have to, when especially when the child already has risk factors, like one parent or both parents myopic, I think we really should, as practitioners, should push for this extra light exposure, almost enforce it. If we can get a cheaper variant with the cloud clip, maybe even Vishwa and I have talked about it. We try and procure that and encourage the parents, really enforce outdoor light exposure, enforce all that we've been talking about, monitoring gadget time very, very closely. I think these are the 2 principal ways in which we can postpone the onset of myopia, especially when there are already existing risk factors. I think this may be, and also it looks like we are stuck with increased digital usage for education in the future. I think these are the hygiene that you talked about, we've been talking about as far as screen usage and the outdoor exposure. I think these are the two key things.
Thanks, ma'am. And so to the eye care world, like to the optometry and the ophthalmology community out there, especially after this, post-COVID, what are your thoughts about, what should we be prepared with in terms of, looking at a surveillance program for, having the decision-making process in place for these, for the myopia progression. So what should we be really doing after this, as in the eye care community?
I think what would be nice is that, we have a really wonderful optometric association of Tamil Nadu with the members who are active, with members who are committed to patient care, to community screenings, who are eager to keep in touch with updates, with the current literature. I think we have a wonderful group here, and I think this group can, and I'm pretty sure that almost many of the members of the group will have children who go to school, will also have, brothers and sisters, kids who are in school. Like, for example, I don't have kids in school, they are in college, but you have other cousins whose kids are in school. I think we have neighbors, friends who are very close to. I think it's almost our duty to approach these schools and ask them to give us a forum, give you a forum to talk about how to safeguard the eyes when you're using gadgets. What are the risk factors? You think that it's parents know. You'll be surprised how many actually don't know. So it is good to talk in parent-teachers associations. It's good to talk to teachers because they are the ones who are actually pushing the use of gadgets. And it may be unknowingly. They may not know what harm it can lead to. They are interested in the academic excellence of the child, in the performance of the child. They want their school kids to be state rankers and national rankers. So they may not know what all other disadvantages this approach has. So I think it's almost our duty to increase their awareness and knowledge of teachers, of parents, and of the children themselves. Number one. Number two, I think we also should offer our services to screen these kids. Screening may have to be done more efficiently with less screening time than even before. We may have to also, like we said, screen them for pseudomyopia first and then look at real myopia. So these are all going to be our duty almost when the post-pandemic schools open and we will have to deal with these children, both the accelerated myopia and the nuanced myopia.
Thank you, ma'am. That was so valuable, I should say, because you brought in very important points to the community as a whole, as how collectively we can, do a lot of service to our patients. And you said a very important point when all of us are really anxious about getting back to the community to just restart our school vision screening programs and things like that. You said it's even more important right now when schools restart, especially to screen for the pseudomyopic component. I think now that all of us as eye care practitioners will be like double charged and then look at ways that we can offer our service with all protective gears in place and other regulations in place. And so thank you, ma'am, for that. And sorry for this typo, it's low dose. So this question is to Dr. Vishwa, that now we have our myopia clinic running very successfully, and under ma'am's guidance, we have this, I think last 2 years now almost, and we've been using low dose atropine as one of the myopia control strategy. Can you share our experience with the efficacy of this low dose atropine?
Yeah. Atropine, as you all know, is a non-selective muscarinic receptors antagonist. So what I mean by non-selective is it would actually act on all of the receptors like say M1, M2, M3, M4, M5 receptors. So So what we do in our clinic is we prescribe low dosage. Low dosage, I mean, is 0.01%, which is commercially available. So we have prescribed and we have data for 64 patients, 1 year follow-up data. Those who have had progression of, say, 1 diopter per year before the treatment and have progressed to about half a diopter per year. So that is what we have seen in our clinic for the 64 patients. Out of 64, 9 patients did not respond to the treatment, which means that these 9 patients progressed more than half a diopter despite the treatment, and 55 patients responded to the treatment. And 3 patients had temporary stinging sensation, and they did not discontinue though, but they did share this experience with us. So what we have seen in our practice is low dosage is very well tolerated. There is no real big adverse events, and it is efficacious in retarding myopia in Indian eyes. What we have also seen is for some of the non-responders, you may ask what is it that we have to do next. So what we generally advise is 1 drop of low dosage atropine every night. So the next step is we have asked them to increase, and with the follow-up probably we will report. So that's our experience with low dosage. Thank you.
Thank you, sir. I mean, the whole myopia control itself can be done as a separate episode, so we're not diving into those strategies now. But thank you for sharing our experience that shows that low dose is efficacious even among Indian children. And so as ma'am was just telling us, like, this is again, the whole outdoor thing into the picture that shows that an increase of 76 minutes per day. So you see that as the time outdoors increases, the risk of myopia incidence really drops. So this is done on children who are not myopic yet. So the only strategy that is right in front of us is to engage in outdoors. And I'm seeing in the audience a lot of you asking about how to do outdoors now, but still we have to really look at all the creative strategies ma'am shared as how we can still engage our kids outdoors. And so I think we are moving towards the end as, okay, now we are all in a very, very, very tricky, very different situation that none of us have faced in our lifetime, and we realize the importance of adopting a healthy lifestyle and staying supportive within our communities and families more than ever. But involving the school is also very, very important at this point, because the school authorities are also quite clueless about how do they want to continue the academic year with all the pressures that they have. So as eye care professionals, we have enormous role, as ma'am rightly said, involving the school, the teachers, and then spreading awareness about all these things that we've learned today, even to the school, as how we can engage the school as one of the important stakeholder in this process, because it's going to be super important in the whole myopia epidemic spectrum to make sure that they are, because now that when the school reopens and everything returns back to normal, the academic pressure could increase more than ever. So now when people are aware of this, by bringing in these promotion materials and parents as role models and providing all the emotional support to all the involved stakeholders is super important. So now we are kind of wrapping up here at this point. So, what are your inputs to the eye care fraternity in general, so that they can handle this whole thing more efficiently now?
So when you were talking about you have to include the school as an important stakeholder, I just wanted to add one point, that the best person to convert and utilize to spread the message is a teacher who is already wearing glasses. I wanted to say a teacher who is myopic, but that would be teacher who's myopic in her view. No, teacher who is actually myopic. or teachers who have children who are wearing glasses, because they know firsthand what it is, what it feels like to wear glasses and how important it is, and how to manage and cope with the emotional stress of being in glasses and finding the refractive error is changing. So they would be your best ally in continuing to spread the message and stress the importance of the work, the seeds that you sow in a school. Because you can't keep going back there all the time, but here's a teacher with whom you can liaison. Somebody that the kids always look up to their teacher. In fact, if you ask the child, what's your class teacher's name, you will see them smiling widely. So they have such a big rapport with the teacher, more than anybody else. So I think it's important to take the advantage of that and use them as your ally to keep the eyes healthy amongst the school kids. As far as eye care fraternity, I think you're on the right track. I mean, the very fact that you've tuned into this webinar and you are interested and have answered a survey and are keenly listening tells me that you are on top of things. You are already interested, aware, and continuing to increase your knowledge. I think that's really is what you really need to stay on top of things, is to keep yourself updated and communicate well with your patients and really truly practice compassion in your practice. I think that will always stand you in good stead throughout your career.
Thank you, ma'am. Thank you, ma'am. Well said. And Dr. Vish, you want to add anything to this, to the optometry community, the optical industry as such? Do you want to give any inputs?
Yeah, as ma'am said, I think they are on the right track, and apart from understanding the updates in the myopia control or control strategies, ma'am did spend adequate time in explaining about the modified risk factors, be it screen time or outdoors. I think that's where I think all the practitioners can start, because I always feel that all of us have to be involved in myopia, and it's not that one odd person is can change things. So I think all of us have to get involved. And one of the things that probably we could offer is, if you happen to see a progressive myopia in your clinic, in case you have any doubt, what is the next thing you could do, we are always available either over phone, or you could refer, or, we would like to offer that service. And I also feel that I think we need to create a task force. As ma'am said, we have to involve a lot of stakeholders, from various, industries. I think we need to create this task force, so that it's not once in a blue moon that we discuss and then just leave it. I don't think it's going to happen. I think we need to constantly meet. This task force should meet, discuss, and update things to the public, to practitioners. I think that's the way forward. Thanks, Liz.
Sir, thank you.
Let's add one thing.
Yes, ma'am.
I just wanted to say that when you sit in the clinic, it's not uncommon for you to hear the parent when you tell them, why is he always with the phone? They'll tell you, both father and mother are working. The child comes home and the child is with the and the grandparent, to keep the child quiet, hands the phone over to the child with a game on it or the YouTube on it. So in scenarios like this, I ask them to bring the grandparent for the next visit. That is what you have to look at. You have to spend time talking to the parent to find out really who are the stakeholders. In this scenario, the parents are helpless. They're not even around. So you need to speak to the grandparent. So identify the stakeholders and involve them, like Vishwa was saying, in your plan. That's all I wanted to say. Thank
you, ma'am. Thank you so much. So as you both mentioned rightly, we we have a lot of resources. So I request the practitioners to take a look at this International Myopia Institute website, where all the recent definitions and guidelines for myopia is presented, and you can go and look at it. This one is even more engaging for practicing optometrist and ophthalmologist, where it's about, see, this is a topic that just got in on April 6th, where it's about grappling with children's screen time during the COVID-19 outbreak. There are many such articles that just summarizes with evidence-based approach as how practitioners bring in a lot of value-based information into their practice, and also can serve your patients in a much more efficient way. So look at these two resources, and this book is freely is available for free download. So post-COVID, the author is Dr. Ang Wong. The editors made this book freely available for download, especially understanding that post-COVID myopia is going to hit the world in a big way. And this is like the only book at this moment that talks about A to Z in myopia. So please go ahead and type this in Google and then get it downloaded and then use it in your teaching as well as for practice, purposes. So this is like a very important book. And I'm just going to wrap up with this final slide that's about this nature-nurture debate. So we didn't get into it much, but as ma'am was telling, like when the parental history, when one parent is myopic versus both parents are myopic, we're going to double the risk of myopia. But this is a very recent study, especially that analyzed about 542,000 European participants, and it came out with the accuracy of myopia prediction just based on genes. It says only 18.4% of heritability can be explained by the genetic variations that they could see. So what does this tell us is that there is another 82% variability which is not explained by genes, and still nurture plays a major role, and that's where all our environmental discussions and modifications that we need to make to our environment comes into the picture. So though we kept saying outdoor, I think getting back in alignment with nature and see how we can get our kids engaged much better with nature is the only way to really look at not just myopia, but I think a lot of issues in general. And this is one of my favorite quote. I agree, like every one of you will agree with this, which is the luckiest things that can happen to our life is a happy childhood. And I think all of us as, in the healthcare have a moral responsibility to look at how ethically we can, provide eye care services to children and make sure that we follow all evidence-based management aspects in practice. And with that, our acknowledgements from all three of us, goes to the team OATN, because like coming back home, so especially to JJB sir and Purnima for putting all this together for us. And then SN Myopia Clinic, so under ma'am's leadership, we all started, and now it's like flourishing. And again, post-COVID, we have to really look at things. And then the epidemiological study team, the myopia study team of SN, which is here, and of course, ma'am and sir are part of the team, and the entire team, which goes to the community and collects a lot of data that helps us to understand about all these risk factors and myopia, prevalence issues and things like that that Dr. Vishwa shared. So our acknowledgement goes to this team. And with that, we end this discussion, like this presentation, and Purnima, over to you for any questions that we need to take up at this point.
Thank you so much, ma'am. It was a wonderful, informative session. Though there were some technical glitches, but still there were many who rejoined us and were enjoying the session. There are a lot of questions for all the three of you. Before that, I'll just like to make a small announcement. All of you, please fill in the registration and the feedback form given in the description box so as to receive your e-certificates. And with the e-certificates, you can get the OCI credit points, 2 points for this webinar. So moving on to the questions. So you had just told about a study about the nature and nurture. There was a question which asked for what are the chances of the child being myopic when only one parent is myopic versus both being emetropic.
So ma'am,
I'm not able to recall the figure, but it's definitely not as much as when both parents are myopic. That is for sure. But even one parent myopic does put the child at a little bit more risk than an intellectual.
So, moving on to the next question. When we are becoming more and more dependent on digital devices post-COVID-19, it will only add to the myopia progression among children and adults alike. How to strike a balance? This was answered, but still, if you would like to put some points onto it.
So I'll ask ma'am again to do that, to reinforce,
Yeah, there's no escape. Look at us, we're all sitting in front of a gadget.
Seriously?
Yeah, if I find WhatsApp on the phone tiresome, I move to WhatsApp web onto the laptop. So that's really we're stuck with it. So we try to follow the 20-20-20 rule. In my case, it's 20-20-20 of going and snacking 20 feet away and coming back. So in one way or the other, the important thing is to take a break. Take a break from the screen. I think that is how we're going to safeguard our eyes or the children's eyes.
Agree, ma'am. Completely.
Thank you so much, ma'am. So, of late, we have been seeing a lot of kindergarten kids with myopic astigmatism. The astigmatism is anywhere between 2 to 3.5. Are there any current studies on why astigmatism is on the increase? Another question I'm just clubbing along. Is astigmatism over 2.5 common these days?
You may want to take this risk. You do a lot of screening.
Yeah. Yeah. So as you have rightly kind of understood the scenario, yes, astigmatism is something that is highly prevalent, especially among the preschool and the toddlers age group. It's not very common to see like more than 2.5. So we have these, what is the age expected norms of cylindrical prescriptions. We can share those documents, like we have the American Academy of Ophthalmology's and the optometry's guidelines is what is considered to be normal. Again, a consensus statement, and what above that threshold needs prescription. But as you rightly observed, we do see a lot of, with the rule astigmatism among children in both clinics as well as in the community. Even in our ESO's school eye health programs, Dr. Anuradha has shared this, I think, recently, that the prevalence of astigmatism is really very high. Now, how does this astigmatism serve as a precursor to the onset of myopia is something that is not answered yet, but we are interested to look at that because, again, not based on evidence, but based on the clinical practice, we do see that some of these kids who have astigmatism also get that additional myopia along with that astigmatism over a period of time. So is it because of the viewing angle? Is it because of the reduced blink and all those ocular pressure related, the lid pressure related issues coming into the picture? So all these are still, we do not have sufficient evidence right now to test it. Yes, we are very sure about this, but you've rightly noticed this, and it's what is important right now is to, number one, of course, follow the same visual hygiene measures. Number two, look at the protocols for prescription and see if the child needs prescription, so that we don't want the child to become meridional amblyopic, because if we don't prescribe, say, 2.5 diopters of cylinder in a child, any child about 3 years, you're going to put the child at risk of becoming amblyopic over a period of time. And number three is that follow up the child very frequently to look at the incidence of myopia also getting added to the astigmatic component. Yeah.
Okay.
Vishwan, I wanted to just touch upon a point. We talked about how optometrists can go to school and start liaising with the school. Could you speak a couple of lines about Kalpa's study, which talked about the ambient light levels in the classroom, and how this may also be something that we as eye care professionals need to highlight and talk about to the school authorities?
Yes, ma'am, sure. So I think many of you might have in the Optometric Association might have heard about this Dr. Kalpa Negilani study. So as part of her doctoral work, she looked at some of these factors such as the viewing distance from the, from the desk, the contrast levels of the blackboard, and then the ambient light levels within the classroom, and all those things, how important it is when it comes to the visual efficiency of the child. In fact, this was well covered even in the media, like in Times of India, about what is that required distance and how big should the teacher really write on the blackboard, because she shared these nice images of some of these schools where you have these green boards instead of blackboards, or even sometimes blackboards, as we all can imagine our school days, where you rub it again and again and again, and the contrast becomes so bad. And then the child that is sitting, especially not from not at the perpendicular angle, but on either side, and how glare and lighting levels can impact the visual performance of this child, and how it can impact children with both like high myopia as well as low vision or any kind of visual impairment. So what are the visual standards that is required for a school setup? And she's come out with this nice draft that was also shared with the the education board of Tamil Nadu, like the school education committee, as like a guidelines draft. So I think we can share the document with the OATN team to share with the participants, also to, as ma'am said, to understand as part of your engagement with the school, even these aspects can be emphasized as how important it is to ensure appropriate environment within the classroom for the child to see well.
Yeah, thank you, ma'am. After you share the document with us, we will definitely share it with the participants. We will have their email IDs to the registration form, so we will share it with the participants. So, as you mentioned about lid pressure and blinking, there is a question which asks, is lid pressure and less blinking and dryness are the main culprits for increased astigmatism, or are there any other reasons?
Okay, so as I just mentioned, we are really not sure about what really causes this astigmatism. It's just a genetic component, or it's all these environmental factors coming into the picture. But some of the early visual development oriented research, even the spatial orientation of the targets in the visual sphere of the child, like a child just getting exposed to not all kinds of spatial frequency spectrum, but only a very little frequency spectrum, can actually get a specific kind of astigmatism. So these were done on kittens, basically, where they looked at how astigmatism develops and things like that. But when it comes to human visual development, yes, there are a lot of forces coming into the picture, as we all know, there could be with the rule moving to against the rule and then becoming with the rule again. So, and lid pressure is definitely one of those factors that are known to influence the corneal astigmatic, the amount of astigmatism that we see. But how much does this influence development of myopia understood, through evidence? But maybe I think in a couple of years we'll have some answers as to,
You must also remember that we don't know for sure if really the prevalence has gone up. We are screening more. There is more awareness. Parents sometimes will even bring kids to the examination in the clinic, even when there are no, the school asked, or because they are wearing glasses, or because neighbors got glasses. So you must remember there is more parental awareness. We are screening, doing full screening, community screening more. So we may be picking up even smaller levels of astigmatism, which may have been asymptomatic and gone unnoticed in the past. So that is something to remember. Unless you have a clear population-based study that looks at astigmatism today and looks at it 5 years later, it says, yes, really there seems to be a higher incidence. Then it's just a guess, actually. Really there is an increase, or it's just that we are finding them.
So good that we are screening more and passing on the information and awareness to the public. So the next question is, in this lockdown period, there might be myopic progression. So can it be controlled later? And but what has progressed is progress. So any measures to reduce the power?
Vishwa, that's yours, Vishwa.
Yeah, as ma'am said, first we need to identify the reason for the increase. Suppose just before the lockdown, if they never had any refractive errors, and suddenly after the lockdown, if you find them to be, say, half a diopter or 1 diopter of myopia, then we know that the reason is because of probably increased screen time. In such scenarios, in the case, we need not prescribe. And I think we need to just advise the patient to reduce the screen time. Probably it will go off. So the point is, when you find errors, you need to identify the reasons. If you know that the reason is because of the increased screen time or increased near work, then probably we could wait for some time. Not prescribe immediately. Maybe you could call them after a week or 10 days, and then see whether it goes off. Ask them to be away from the screen, or ask them to read less or be no reading for at least those days. And again, you evaluate and you find that the error is not there, then it's fine. Suppose you find that the error is still existing, then probably cyclophagic diffraction would tell us, the management strategy.
So you mean that there are chances of reversible quarantine myopia?
Yeah, depends on the reason. If it is because of that, probably yes. And if it's going to be a short term, then yes, it is possible.
Good to know that, sir. So there are many who have asked if we can share Dr. Varshini's document among school groups. And is it possible for you to share the document with us?
In the group, if we can share the document, she did say yes. So I think as long as she's acknowledged, and the document is a PDF which has her name and the hospital affiliation, I think it should be fine.
Okay, thank you, ma'am. The clip device. This one, you're on mute.
Okay, I'm on mute. So basically, that's one another point that we have to be prepared with. Like tomorrow, I think we are even imagining a time period when, along with spectacles, we might even prescribe these cloud clips also, which I think is happening in some parts of the world. So this is what we were talking about. So this is basically what, as you see here, these are infrared sensors. The sensor is going to kind of monitor the child's going distance as well as the angle of reading, and it's also going to kind of take the ambient light levels inside. So it's going to give you the number of hours of near activity, the number of the ambient light levels that the child were exposed to, and outdoor just based upon the viewing distance. It's going to calculate all this. So we have started to work with these devices in the myopia clinic, and we've got some data. And so from this device, it's you can objectively quantify the amount of near work outdoor exposure. And what is more important is that it can alert the child that when the child goes very close, which is less than 20 centimeters, it's going to alert the child as like kind of come back, and it's going to blink and tell the child warning that you've gone too close. So this along with a small rubber band like device can just get inside the temple of the spectacle. So especially whenever we are bothered about this myopia progression in children who are already at risk, or children who are on the verge of developing high myopia, because we know about the visual morbidity of these issues, it's important to monitor these things. And there are many other devices also apart from cloud clip, which are all these fitness tracker based devices, which could be even like worn on hand And I think Dr. Vish, you can add about the other devices that can be stuck onto the collar or something like that. So many devices that's come in the market. This is one device which was, I think, really tested and validated for use among children, especially to monitor the near work and outdoor exposure.
In fact, there are, as you said, there are some mobile phone-based apps, but I wouldn't suggest that, because this particular cloud clip is validated. So it is important to use a device which is validated against mobile phone app. You want to just check with mobile phone app, it's fine. But when you want to really understand in a population, then it is better to opt for a device which is already validated.
And as you see here, it's very, very weightless, 4.7 grams. So we all tried to put it on our glasses just to see how it's working. And we collected data for 1 or 2 days. Like Aparna, the doctoral researcher of the STEM team, so she's working with these devices. So she just tried to collect some data from these, and after which COVID came in, and so the devices are also locked down now. So, yeah.
Okay, so we're running short of time, but have a lot of questions, so we'll take a few. This one is for Dr. Vishwa. What percentage of low dosage atropine is used, and is there any rebound effect after stopping the treatment? And with the low dose atropine, do you also give full correction of myopia?
Yeah, it's a good question because ATOM study has clearly showed that ATOM study, in fact, ATOM 1 used 1% and they have clearly showed the rebound effect. So we have taken a conscious decision when we start when we advise low dosage I mean is 0.01%. That's the one which is commercially available. So we prescribe 0.01% atropine. And the most important thing here is do not stop or do not discontinue the drug. So that is what is very important, because as the studies have shown clearly, if you discontinue the drug, then there would be rebound effect. So for that reason, it is advisable not to discontinue.
Okay. Thank you, sir. So I would like to invite Dr. KK on board to give a thank you note. KK, sir.
Thank you. Thank you for a wonderful panel discussion. And I'm hearing myopia after a long time, especially directly from people who are really working. I think most of the time we tend to read, especially myopia has become pandemic for the past more than 10 years. And people are talking on near vision, near work activities. People are talking about outdoor activities. Interesting thing, there are a lot of take-home message for independent practitioners. And thanks, Dr. MS, for giving a guideline as to what need to be done post-COVID, especially on during the practice, and also if we can't do the outreach activity, we can easily do the counseling and ensure that still we can prevent occurrence of myopia from the progression of myopia also. And very interesting. Thanks, Vishwanath, for the wonderful STEM and sharing that result is something very phenomenal. Thank you, and it looks very positive and direction. Probably many takers will be there down the line once your results come out. I think to best of my knowledge, it is the first Indian study. And of course, the prevalence data is also changing compared to northern part of the country, urban area to rural area. Probably we have to learn, I understand, we have to learn more from the area. I think I understand recently I was reviewing through one of the papers on rural. It looks very meaningful, especially the kind of the questionnaire which they did. It looks a lot of learning for urban parents from the rural children. Probably that will be of great importance, especially to prevent myopia. And in India, probably we are in the right juncture that we can prevent rather than working more on how to stop the progression. And thanks, Rizwana, for wonderfully planning this whole session. And thank you, Purnima and Jyoti Balaji. And thank you all for who asked the wonderful questions. Thank you very much.